Hi, kids. So let us continue with our discussion regarding your adrenal cortex. So, just a recap regarding what was discussed last meeting. So, we are done discussing regarding the histology and anatomy of your adrenal gland. And then we've also discussed already your aldosterone and the half part of your cortisol. So we ended with this one regarding the circadian rhythm of your cortisol. So now let us proceed with its clinical significance. So as always, when we are looking at the clinical significance of your hormones, we need to check whether ano yung mga conditions na related to it when there is an increase or a decrease of its concentration. So one thing that And the first thing that we will talk about is with regards to adrenal insufficiency. So, meaning to say, let us discuss about when there is a decrease in the concentration of your cortisol. So, one example of that condition is what we call your Addison's disease, in which it can either be a primary or a secondary condition. Primary siya, especially if the problem is in terms of the destruction of your adrenal cortex. So usually what happens here is that there is a destruction of 90% of your adrenal cortex. Now, Addison's disease may also happen due to secondary causes. Secondary, na in a sense that the problem is in your pituitary gland, and what happens here now is that there will be decreased ACTH release, which in turn will also decrease your cortisol. Now, just take note, kids, that with regards to Addison's disease, hindi lang po si cortisol yung possible na mag-decrease, your aldosterone may also decrease because looking at the primary cause of Addison's disease, destruction biya siya sa adrenal gland. So it does not concentrate only on the zone where your cortisol is being secreted. So meaning to say, aldosterone may also be affected. But mas evident lang yun ang pag-decrease sa concentration ni cortisol. So these are your different signs and symptoms. So stated here, you have your hyperpigmentation, weakness, fatigue, anorexia, adrenal calcification, you have your nausea, and diarrhea. So, in terms of the signs and symptoms, we could actually group them in accordance to how frequent are they present in a certain individual with this condition. So, 100% of those individuals, kids, will experience weakness, fatigue, anorexia, and then weight loss. 90% will have hyperpigmentation. 50% will have nausea and diarrhea or nausea ba na siya pag-pronounce. And then only about 10% will feel pain and there will be adrenal calcification present. This is just like how we discussed your thyroid autoantibodies. Now we are just actually looking at the frequency as to how frequent the signs and symptoms will be present. So let's move on to the laboratory test. So, how are we going to identify or how are we going to diagnose patients with adrenal insufficiency? So, pwede by checking the baseline cortisol. When we say baseline, yung pinaka-first na sample natin na kukunin sa patient. And then we can also measure ACTH. Then we have this what we call your concentropin administration. So, for your serum cortisol level, there are three different assays that can be used. You have your fluorometric assay, your radioimmunoassay, and chemiluminescent, and you have your HPLC with tandem mass spectrometry. And actually, between the three, the famous one is your HPLC. Even in research kits, the current trend of research, whether you do sample processing or trying to detect uh, levels or concentrations of a certain substance, HPLC good na ang ginagamit na because in terms of sensitivity, grabe kataas ang sensitivity niya and it can actually detect as kanang mas in gamay na kay na concentration kaya gyapon niya i-detect. So for the baseline cortisol level, kids, you need to uh, do blood extraction around this time, since that is where your cortisol is at its highest peak. And if it is the normal range is that it should be less than 3 micrograms per deciliter or 83 nanomoles per liter. While in random cortisol, syempre dapat iba yung range. Pag random, when we say random, kids, it is taken at any time of the day. So for your random cortisol, the normal range is that it should be less than 10. So ACTH, again, plasma ACTH can be measured, since as discussed a while ago, pwede rin naman secondary yung cause ni Addison's disease. So pwede natin i-check mismo ang level ng ACTH nyo. So the assay that can be used to measure its concentration is your two-site immunoradiometric assay or your chemiluminometric assay. And that, when you collect blood sample for ACTH, you need to make sure that your EDTA top is really cold. And even all throughout testing, kids, dapat cold ang environment. It should be kept in an ice bath. So this one sa baba, this is your normal range for your ACTH. You have your 2 to 12 picomoles per liter, and which is taken between 7 a.m. to 10 a.m. So another test is your ACTH stimulation test, which can be done any time of the day. So here, you need to, of course, get first your baseline serum para may basis po tayo whether nag-increase or decrease yung concentration ng cortisol nyo. And then you administer cosentropine. So what is this cosentropine? It is actually a drug, a commercial drug, and it is actually an exogenous ACTH. Exogenous, or kumbaga it is commercially prepared. So upon getting the baseline serum cortisol, hatag mo og 250 micrograms of cosentropine, and then after 30 and after 60 minutes, collect serum for your cortisol. So the normal response, kids, should be na mag-increase ang inyuhang cortisol, since remember, gitagaan biya ninyo siya og ACTH. So meaning to say, there will be an increase in the concentration of your ACTH in the body, which will signal to also increase the release of your cortisol. So again, this is the normal response na dapat mag-increase. But since the patient has Addison's disease, so what happens here is that your cortisol will continue to decrease. Next, we also have this overnight metirapone test. Metirapone, kids, is still a drug in that its action is in terms of inhibiting your beta hydroxylase, 11 beta hydroxylase. So, asan yung 11 beta hydroxylase? This one, kids, looking at the right side na schematic diagram nyo, this is here. This is the enzyme responsible in converting 11-deoxycortisol to cortisol. So, after uh, uh, before administering your metirapone, still dapat nagyapon may baseline ani kids, and then by 12 midnight give metirapone orally, and then by 8 a.m. measure the cortisol and the 11-deoxycortisol. So what would be the normal response? Now your 11-deoxycortisol, kids, will be increased. Kasi take note, ang na-inhibit is dito na portion. So you would expect that by giving your metirapone, wala tayong cortisol, so ang mag-accumulate is your 11-deoxycortisol. But in patients with adrenal insufficiency, with Addison's disease, even your 11-deoxycortisol, kids, will decrease. Because again, going back to the cause of Addison's disease, sira yung adrenal gland nyo. So even these other hormones, even these other precursor hormones of your cortisol should also be decreased. So we can also do your CRH test. So first, get the baseline of your ACTH and cortisol, and then do IV administration of 100 grams OCRH, kids. O here stands for your ovine. Kumbaga, Mo na siya ang source nato of getting the CRH. And then collect blood every 15 minutes for 60 to 90 minutes. So the normal response here is again, it should increase diba, more than 20 micrograms per DL kasi asa ginasecrete ang inyong CRH that is in your hypothalamus. So an increase of your CRH will also increase your ACTH, which will also in turn increase your cortisol. Then again, the expected result for patients with Addison's disease after undergoing CRH test, after getting a blood sample for CRH test, magbaba gyapon siya. Walay effect ang paghatag sa CRH test sa mga patient na naay Addison's disease. And just take note that the peak of your cortisol after getting an OCRH injection, it will happen at around 30 to 40 minutes. So we are done with adrenal insufficiency. Now let's proceed to hypercortisolism, or if there is an increase in the concentration of your cortisol. So one disease or condition there is what we call your Cushing's syndrome, in which it is characterized by adrenocortical hyperfunction. So again, Cushing's syndrome, there is an increase in the production of your cortisol, so kaya hyperfunction. Now, Cushing syndrome kids, daghan o possible na reason or cause as to why magkaroon og ingani ang isa ka patient. Kaning naa sa second bullet ninyo kids, this is referring to your secondary na cause in which there is an ACTH secreting pituitary adenoma. So there is an adenoma in your pituitary gland causing na magsigi og release sa inyong ACTH, and therefore your cortisol will also increase. Again, there are a lot of causes. So another cause is that it can be iatrogenic in origin. When we say iatrogenic kids, this means that a certain individual is actually undergoing a medical treatment, and due to that medical treatment na ginatake niya, mura siya effect. When we say iatrogenic, mura effect siya sa imuhang medical treatment. So kana lang pud no kay syempre any drugs man gyud kids na ay side effects. So nakalain lang kung ani man ka-worse ang side effect, then might as well look into it. And then another cause could be that there is ectopic production of CRH or ACTH by a tumor. So when we say ectopic kids, meaning outside sa supposed to be expected area kung asa sila ginasecrete. So for example, kaning CRH, diba ang CRH sa hypothalamus man gyud na siya ginasecrete. So when we say ectopic production of your CRH, meaning there is another organ that is producing CRH. So kaya ectopic outside. And then primary adrenal malignancy, so this is related to the primary disease. Ang mismong na problem is inyuhang adrenal gland. So for this image kids, this is just referring to your feedback loop mechanism, presenting all three disorders from your primary to secondary, and then just correct this one, si letter A. This should be tertiary. See, we are looking at hypothalamus here. So, tertiary, hypothalamus. Letter B, secondary, kay pituitary. And then letter C, kay primary, your target organ, which is your adrenal cortex. So, I guess na-explain man siguro na ako ni Ugtarong sa inyo ha, na kung asa man ang area na ay problem, kumbaga, it does not affect, dili affected ang result niya sa kung sa man ang nasa outside environment. Parehas ani kids, pag-abot sa inyuhang ACTH. No? Siyempre, ang problem na sa inyong pituitary gland, so muna increase sa ACTH, which will in turn increase your cortisol. And siyempre, sa pag-increase inyong cortisol, it will give a negative feedback to your hypothalamus. Kaya, as emphasized here, baba inyuhang CRH. But ang pagbabaan na sa inyuhang CRH, yun na nga, since ang problem na ay kay pituitary gland, so your ACTH is unaffected by that decrease in CRH. So these are the signs and symptoms of patients with Cushing syndrome, central obesity, or obesity, meaning to say na alang usually ang deposit sa inyuhang fat sa body trunk mismo or sa abdomen na area. Next is your buffalo hump. So, kanina siya kids, oh. Ayan. So, ayan, fat pads or buffalo hump. And then, we have your moon phase. Of course, moon phase ito po. Na kanang murag nagburot og taman ang nawong. And then, we also have your purple striations, which is this one. Na it looks like a stretch mark, but when you try to actually look into it, it's really color purple. And then you have your adrenal diabetes relating to the function of your cortisol wherein it increases your glucose level and thus possible good na magkasabayan sa Cushing syndrome is diabetes. But it's just that it is emphasized na adrenal diabetes because again the problem is your adrenal gland. And then Cushing syndrome may also cause your beta cells to die. Beta cells in I think this is referring to your pancreas because of course too much sugar good kids in general could really damage your cells. So these signs and symptoms can actually be summarized into pwede na to siya kumbaga natin mnemonics na pwede tandaan which is B is fat, B for buffalo hump, A for acne, E for easy bruising, then fat, F for faces, your moon phases, A for arm wasting, and T for truncal obesity. So truncal obesity or central obesity, that is just the same. So, how to diagnose patients with cortisolism? One thing that we can do is by checking the presence of free cortisol in the urine, which is a sensitive indicator of endogenous cortisolism. Now here, why is there presence of free cortisol in the urine? So the second bullet would actually explain that. Now, when serum cortisol exceeds the capacity of its carrier protein binding, free cortisol levels rise rapidly, increasing your free cortisol filtered in the urine. So, how do we explain this one? Kumbaga, kids, remember that your corticosteroids na ay mga binding protein. So, syempre, the more na nagataasan yung cortisol and gina-release sa circulation, dapat nakabind ba yun na siya sa inyong carrier protein. So, syempre, the more cortisol na gina-release, the more na naga-increase ang binding sa inyong carrier proteins. But there will come a time na masaturate na niya. When you say saturate, kids, karaganing mahurot na ang tanan ninyong mga binding proteins, tanan binding proteins, mahurot na og attach sa inyong cortisol, then that's the time na yung mga naiwan na mga cortisol nyo, that will be excreted out into your urine. Thus explaining why free cortisol can be found in your urine. But the problem with urine-free cortisol testing, kids, is that it is affected by hydration, especially if your patient drinks around 3 to 5 liters of water per day. And actually, kung mag-reach ganit jud daw na siya 5 liters per day, a 64% yun daw of increase will be observed. So, if ani ka kusog, mag-hydrate ang inyong patient, then the test that would be better na gamiton is this one, your urine 17 hydroxycorticosteroid. Now, your 17 hydroxycorticosteroid, kids, these are breakdown products of your cortisol. So, being a breakdown product, being a metabolite, meaning to say they are excreted through your kidneys. And the advantage of measuring 17 hydroxycorticosteroid, kids, is that it is unaffected by any volume change. So now let us go to your 24-hour urine cortisol. Kids, as always, the best sample good, especially if you wanted to measure specific substances, that will always be your 24-hour urine. Ang ano man good 24-hour, so that there is no over or underestimation of the concentration of your substances. So, muna, best yun na si 24 hours. So, 24-hour urine cortisol is measured by tandem mass spectroscopy and that it is the most sensitive and specific for excess cortisol. So, you need to collect your sample overnight, especially around 10 to 8 a.m. and it should be factored by creatinine because creatinine could actually tell us that there is adequate urine sample that was submitted. And your 24-hour urine cortisol is unaffected by the levels of circulating CBG. So, another test is your dexamethasone suppression test. Take note of your dexamethasone. This is a cortisol substitute. Mura siya katong ato ang gimension kaganina na exogenous ACTH na po tayo exogenous na cortisol. Tipong gibuhat siya outside sa body sa isa ka tao. Now, what happens here in your dexamethasone suppression test is that since this is a cortisol substitute, then there you would expect that there will be a suppress in the ACTH level in your pituitary gland and a normal ah suppressing ACTH if your pituitary gland is normal and cortisol secretion if your adrenal gland is normal. So this is an overnight dexamethasone suppression test because this drug should be administered at around 11 p.m. And then by the time na mag-collect mo blood sample to check for your ACTH, so again, the normal na i-expect yun is masuppress. Okay, syempre, taas naman ang cortisol, kay naghatag man ta og exogenous na cortisol, then ang effect, negative feedback, dapat mababa si CRH, dapat mababa si ACTH. And that a suppressed free cortisol kids between 8 to 9 a.m. will also mean that there is a negative test that your patient does not have Cushing syndrome. Next, we have your CRH stimulation test, in which this is very helpful if you wanted to distinguish what type of Cushing syndrome does your patient have. So, it could either be central or primary. And as usual, 8 a.m. pa rin because that is the highest peak of the substances, cortisol and ACTH, especially good sa ACTH. So to explain the different types of Cushing syndrome, we have this ACTH independent and ACTH dependent. So, kung tanawon ninyo ang causes, kids, actually, pwede na nayon ninyo na siya. You will already have an idea kung unsa ang results. Since ACTH independent is of adrenal cause, then ang inyuhang cortisol ani kay mag-increase. While your ACTH dependent, this is pituitary or ectopic ang source, meaning this is secondary. So, ingani po na nga itong i-expect na result. So, ngano ingani kids? Again, independent. So, meaning to say, the cortisol value here is not looking at what is the concentration of your ACTH. And since we are trying to discover Cushing's here, so kaya by the time na mag-CRH stimulation ta, cortisol will increase, ACTH will decrease. When in fact, kung decrease si ACTH, dapat decrease pa po din yung cortisol. So, muna siya ginatawag na independent. Unlike here in your ACTH-dependent secondary man, so dapat magtanaw ta pinakauna sa value ni ACTH. So, since si ACTH increase man, then of course, cortisol will also increase. So, ana lang na ang different types of Cushing syndrome ninyo kids. So, this is actually already the overall kanang murag schematic diagram in terms of how to properly diagnose and do treatment and management of your patients. Then again, in our case, ayaw na di na ninyo kailangan memorize on kids, di na kailangan sabihan. So, kato lang po ng inyuhang tandaan. Katong mga test na gipang-discuss nato just a while ago. So, we are already down to 2. Done na kay mineralo, done na kay gluco. So this time around, let us discuss your gonadocorticoids, the last hormone secreted by your adrenal cortex. So just remember the word gonads here, since gonads will always relate to your sex hormones. So going back, the other name for your gonadocorticoids is androgens, and that they are synthesized in your zona reticularis. And if you could still recall, katong table na ako ang gipakita in terms of kinsa ang major hormone, then dara inyuhang DHEA. So by this time I know balunan mo ay nasulat na ang meaning ni DHEA. So that is dehydroepiandrosterone. And there are cases, kids, that your DHEA will become sulfated. will become sulfated because of the presence of the enzyme sulfotransferase. But then again, if there is a difference in the function, actually kids wala. Difference lang sa structure kasi DHEAS na ay sulfate, but in terms of function, they are still the same. So here are examples of your androgens and estrogens that can be secreted in your adrenal cortex. So for androgens, we have your androstenedione, your testosterone, and your 5-dihydrotestosterone. Whereas for your estrogen kids, there are three types: E1, E2, E3. So actually, if you try to get its full name, nadaan sa name ang numbering. So you can say, oh, E1 estrone, E2 estradiol, and E3 is estriol. So kaning taga-estrogen, nani sila kanya-kanya pod na kumbaga asa sila commonly found for estrone kids. Siya man ang number 1. Estrone. Estrone is commonly found in menopausal women. Estradiol sa non-pregnant individuals, while estriol kids is sa pregnant. So of course, asa ta mabilong na category, that should be on the non-pregnant na side. So meaning to say the estrogens that is prevalent in our body is your estradiol. So, what are the functions of your androgens? It can contribute to the onset of your puberty, the appearance of your secondary sex characteristics, and your sex drives. Now, what are the secondary sex characteristics? We'll talk more about that as we go along our discussion. So, let us now focus here sa last two na bullets ninyo. So, you might wonder na, ma'am, ano man mga lalaki less than 5% ang testosterone? Where in fact, that is their major sex hormone. Tapos pagabot sa babae, taas kaayo 40 to 65. Kids, kaning percentages nagipang represent diri. This is referring to adrenal medulla in origin. Dili siya kanang specific gyud na kanilang kay lalaki, kanilang kay babae. Again, these percentages represent the value or concentration of testosterone in males and women in your adrenal gland. So, ato lang po nang i-discuss as we go along. Sa may atong pwede pa idungag about ato na statement. So, here, going back to the synthesis of your adrenal gland, kanina portion kids, actually, dili pa ni siya maudyo ng end sa inyong androgen. So, that is why I placed another image here. Kung tanawon ninyo diri na portion, napakita man kung unsa gyud ang step-by-step conversion until such time that you will be able to get your testosterone and your estrone. So, dagdag. I-memorize kids, ana lang. So, yun, by level gihapon ni ang enzymes ani kids. Kung unsa ang presa ni aromatase, or kung napadayon pa ni siya na ay 3-beta HSD, again, by level pa rin naman po yung enzymes. So this is your feedback loop mechanism, kids. And what is unique here in your in relation to reproductive system, okay, we're talking about estrogens and testosterone man kaya, in terms of the reproductive system, duha na siya ka-hormone ang gina-release sa inyuhang pituitary gland. So, na-mentioning isa, that is your luteinizing hormone. Another one is your FSH, your follicle stimulating hormone. So, depende kung unsang needs ato ang body or kung unsa ang dapat process na mauna, then, saka pa na ma-release si LH ug FSH. But in terms of their function, kids will leave that during your lecture na lang. Basta just remember here that these are the feedback loop mechanism for the androgens. So, CRH pa rin sa hypothalamus, and then ACTH or your LH and FSH. And as you can see, there are two possible na target organs here. Okay, kanimang pong other organ, kaninyuhang sex organs, they also produce man testosterone ug estrogen. So they are part in your feedback loop mechanism. So another question here, kids, is that what would be the source of sex steroids in postmenopausal women? When we say menopausal, manggod kids, di ba, nag-stop, dili na ginadugo, nag-stop na yun ang kanang mga related to that process. And syempre, once mag-stop, then meaning to say, dili na kaya sa ato ang ovaries na siya na lang man perminti magbuhat sa inyuhang, sa ato ang mga hormones sabi na kay androgens ug estrogens. I think gani, dili ano, but anyway, so yun na nga, when we say na menopause na si babae, dili na naga-function gyud fully si estrogen. So that is why what is being emphasized here in terms of the source of sex steroids sa postmenopausal women is that ang magpabili na lang yun ana si adrenal gland. So what is the action of adrenal androgens in men? Looking at this area, kids, syempre, kaning naa sa inyuhang left side regarding the conversion of cholesterol until na makuha si testosterone. So this is in relation to your synthesis. What happens now, once we already have your testosterone, it will now go inside the cells. And this is an example of the cell found in your prostate gland na most of your testosterone here in your prostate gland is actually converted to this what we call your DHT or your dihydrotestosterone. So the enzyme that will catalyze that reaction, kids, is your 5-alpha reductase. So unsang difference karon ngano na pa man joy dihydrotestosterone, ngano na pa man joy testosterone. Now dihydrotestosterone, kids, in terms of function, they're actually almost the same with testosterone. It's just that siya ang mas potent and siya ni ang naay stronger effect. Again, DHT, your dihydrotestosterone, is more potent and has stronger effects compared to testosterone. But in terms of its specific, the function, they are actually just the same. So now we go to the metabolism of your DHEA. The box on your right side is representing the synthesis. The box on your left side is referring to the metabolites. And the major metabolites of your DHEA are actually these two, kaning 7-oxo-DHEA and 7-alpha-hydroxy-DHEA. Kana na sila ang major na metabolites. And of course, being a metabolite, then that would mean that this can be detected in the urine or can be present in the urine. So these are your male secondary sex characteristics. Again, part of the role of your androgens is the start of kanang naanam mo yung mga secondary sex characteristics nagabigin na. So as written here, actually if you try to read this one, if we will try to read this one by one, kumbaga, in general, this is regarding what will be the effect of your body during puberty. Diba, testicles will begin to enlarge, scrotum turns darker and coarser, pubic hair begins to grow, your body grows taller and heavier, kana na siya, and so on and so forth. And this is actually, sa right side sa inyuhang table, diri nakapresent ang unsang usual na age range na kaning mga secondary sex characteristics mahitabo or mapansin. So how about sa females, kids? So of course, sa females, breast will begin to develop, pubic hair begins to grow, vagina will grow longer, and its labia will also become more pronounced. Siyempre, pinaka evident man gyud kaayo na kanang mao biya ning ginaingon, di ba, nala dalaga na gyud ni si kana kanig yung menstruation. Now, once your menstruation begins, that is a sign that you are starting your puberty. So, in terms of the clinical significance, sa mga lalaki, one evident yun na kanang effect sa kaning ay sa kaning mga lalaki is ang kaning ginatawag nato na na feminizing effect. When we say feminizing effect, meaning to say that the physical appearance of this male is actually more like sa female. Like for example, karoon og murag presence sa boobs, dili kay siya grabe og muscle mass, na-decrease sa hair growth, na-decrease ang testis size. So kana na siya. Now the lower testosterone here, kids, is actually referring to adrenal gland in source. Adrenal glands na source. And then here sa mga babae, kung feminizing effect man sa mga lalaki, masculinizing effect sa mga babae. So meaning to say, if you try to look at an example here on your right side na yun na nga, babae sila but they actually look like a male. And even ang kanang too much or there is excessive hair, which is termed as your hirsutism, that is an example already. Kay, syempre, mga babae, di man gyud na typical na bunguton. And then you have acne, you have male pattern, baldness, menstrual irregularities, and virility. Meaning daw sa virility, kids, is actually synonymous to saying manliness. Ana daw na siya. And then for the diagnosis, pinaka nindot yun na i-test ani kids is your DHEA or your DHEAS. Now, why is that? Because this hormone is site-specific. Na tipong, walay lain nag-produce iya sa adrenal gland lang. Kaysa naman mag-test ta og androgens or testosterone or kanang inyuhang estrogen kids na syempre, nabiya siya laing kanang source pa. Diba? Pwede biya ang ovaries ug ang testis ninyo ana ang mag-produce. So again, it would be best to measure DHEA or DHEAS because it is site-specific. It will tell us if there is a problem in your adrenal gland mismo. And then last, your urine 17-keto-steroids. So these are actually metabolites of your testosterone. So again, kindly take note that your 17-keto-steroids, these are actually metabolites of your testosterone. And of course, being a metabolite, then they are excreted to your, they will pass through your kidneys and then excreted along with your urine. Ayun, kids. So that's it. That ends our discussion regarding adrenal cortex. So again, please do not forget to purchase your Scantron sheet and we will have a quiz regarding this one and then padayon lang po taog discuss adrenal medulla na dayon. So thank you so much for listening and if you have any questions, feel free to message me or feel free to ask by the time na makitaan ba ko ninyo or mag-meet na ta by Thursday.